All right, so we're gonna, this chapter is biliary cancers. It's kind of a tough topic for residents, to be honest. So I don't know. This may not be as interactive as I normally try to make it. Looking at Savastins, there's basically like 2 paragraphs on cholangiocarcinoma, so it's kind of an advanced topic for residents. But we'll try to get through the basics just so you guys have an understanding of kind of what we do with these cancers. The first things to understand is just some of the anatomic considerations. So we went over this with the R1s and R2s, but maybe one of the interns can run me through this again. So what's this green part called, the yellow part, and then this sort of weird pinkish? What are the names of these things?
Ryan Fahey can answer those questions for you.
I'm sure he can.
Green's the hepatic duct, yellow is cystic duct, and red is the common bile duct.
Yeah, so common hepatic duct is above. And this is important because when we talk about these tumors, we want to be very specific about their anatomy because it changes the surgical approach quite a bit. And then what do you call this part right here, Ryan?
Confluence, the left and right duct.
Yeah, but where they come together, what's that called?
Hilum.
Yeah, so yeah, it's a little confusing. I would call that the confluence, but the hilum is the term for where basically the portal triad comes into the liver. So the hilum really, there's this thing called the Hylar plate, which is where the liver and the bile ducts, as well as the arteries and portal vein interface. And it's usually kind of right on top of the bile duct here. So the confluence of the bile duct is usually extrahepatic, but it's sort of wrapped in this fibrous stuff that's right near the bottom of the liver. And that's what we call the Hylar plate. So often in these operations, we'll talk about dropping the Hylar plate. And what they're talking about is basically lifting the liver off of all this stuff so that you can access the confluence. And then another intern talked to me about what these are right here. Which one is which and what are they called?
Maybe Maria Navarro can answer that.
The anterior and posterior.
Good. What's this one?
Anterior.
Yeah, good. So the right, goes into an anterior and posterior, and that's true for the portal vein, the artery, and the bile duct. And those 3 structures typically run together, but they don't always. But it's super important to understand the ductal anatomy for particularly a Hylar Calangio, where you're trying to figure out kind of what is open and what is not, what has tumor in it. So you really have to have a good understanding of how these things branch. So we'll go over some other anatomic variations, but this is the typical anatomy. The other thing I want you to appreciate is that the right duct branches really, the flow is down, not up. So we don't talk about branches, we talk about confluences, but the right confluence is generally very close to where the left and right come together. Whereas the left usually has a much longer, it's actually not drawn that well in this picture, but if you can appreciate, this is a caudate lobe branch. So this can be taken with impunity. The caudate lobe has all kinds of drainage. So you can take the caudate lobe branch pretty easily, but the branches that are really meaningful, draining segments 2, 3, and 4 are way out here. So you have this long segment of what we call extrahepatic bile duct on the left, whereas typically the right goes into the liver kind of right here, and then it starts giving off its branches. So you have a very short segment of what we call, the proper right duct, whereas the left, you have a much longer segment. And that's important when you start talking about reconstruction, because the left, just has more room to resect. So if you have a Hylar Calangio that's right at the confluence, you can get further onto the left duct without significant consequences and without having to sew to like multiple branches. Whereas on the right, it starts branching pretty early. So if you have to creep back onto the right, you're going to have to sew to at least 2 branches. And we'll kind of get into that later, but these are just the anatomic considerations to sort of keep in mind. And then the other thing to keep in mind is the relationship between the portal structures. So we went over this last week, but if there's another intern, talk to me about what this is, and then what these other luminal structures in the porta are and what their relationship is. Which one's in the back?
The two other students that haven't been called on are Hess and Carson, if one of you guys wants to answer this. So, what portal structures
You
are we
haven't-
looking at on ultrasound relationship?
So this is anterior, this is posterior, this is the vena cava, I'll give you that. And then the portal structures kind of lay, depending on where you catch them, they sort of lay right on top of the vena cava. And so there's one in the back and then two in the front and one there, in the two in the front, one's on the right, one's on the left. Any idea what those relationships might be?
So Carson says the big one posteriorly is the portal vein,
Yep.
and then how, which is left, which is right?
I'm sure you got it right. So let's just come back to this picture we were just looking at, right? So if you were paying attention, we already gave it away, but the common duct is generally on the patient's right, and the artery, again, the artery comes from the celiac, so it comes from the midline, so it only makes sense that it would come up the left side. And this is the typical relationship. And the one key thing to notice for cholangiocarcinoma is that the right artery goes right behind the common bile duct or the common hepatic duct in this picture. So that is super important for cholangio because cholangio is a cancer of the duct itself. And so what structures might it be touching and might the cancer be touching? Specifically, the right hepatic artery is a very important structure. And that comes into play too when you talk about common bile duct injuries. So a very common pattern of injury is an injury to the right hepatic duct and the right hepatic artery, which you have to take into account when you're thinking about what to do to fix that problem. If you have a ischemic right lobe, you know, depending on that for your reconstruction is probably not wise. So sometimes those patients require a right hepatectomy. It's a little bit neither here nor there, but just to drive home the point about this relationship that that the right hepatic artery dips directly behind the common hepatic duct in most patients, not all, probably about 70% of patients have this anatomy. And so if you have a cancer sitting in this duct, you really got to think about where that right hepatic artery is and whether or not it's involved. Okay, so some anatomic variations. So this is the portal vein. So this is the kind of classic classifications of the portal vein anatomy. So typical, most people call these Nakamura, at least the way I was taught. So this is a quote unquote normal type A. So you have a trunk of a right portal vein and then left, and they come together as a confluence. So this would be kind of like the biliary anatomy we just described, where you do have a right portal vein that it has some length to it. And then the rest of them, essentially the right portal vein has no length to it. So that means that the anterior and posterior come off separately. So type B is just a trifurcation. And then this is what's called a staged portal vein. So the right posterior comes off first, and then the right anterior and left are sort of the confluence rather than the right and left. And then this is the type D is less common. These are, you know, on the order of like 2 to 3% of the population. But here you have a right anterior portal vein that has that's basically off the left. So you have this long, what looks like the left, and then the right anterior is joining up with the left. The reason that these matter, right, is that you can get confused. And so let's say you're dissecting out the portal vein and you get this, and you think, well, I have the right and I have the left out. And then let's say you're going to do a left hepatectomy. And so you ligate this portal vein thinking this is the left, and now you've ligated the right anterior as well. And now you're potentially only leaving the right posterior section or sector, which is less liver. So if you're counting on that right anterior sector to give you the volume you need for the patient to not have liver failure post-op, and then you take that portal vein on accident, that's a bad move. So in the OR, what we do, right, is we dissect these things out, we loop them out, and then, you know, you can either POTS it or put a clamp on it, whatever you want to do, but obstruct the flow somehow, and then put an ultrasound on the different sectors of the liver and make sure that they all have portal flow, and you do the same thing with the artery. So it just takes a minute to put an ultrasound on and confirm flow. The other thing, obviously, is that if you have pre-op imaging, you should be looking for these different anatomic variations within the portal vein. The portal vein is very easy to see on CT, whereas the biliary system is not. But you can use this as a guide to your portal anatomy. But just be aware that these variants are out there and make sure you're looking out for them. If you're ever in a situation, in a trauma or something like that, where you don't have a good pre-op CT, and you can't, you don't know this anatomy, looping things out and putting an ultrasound on the liver is the key. And then these are very rare where you have kind of this distributive right system where you don't have big branches. That's pretty unusual. All right, questions about any of that? Oops. All right, so same thing for the bile ducts. So you can have different variations. So this is what we call kind of normal anatomy, quote unquote, right? So you have a common right with the anterior and posterior, and then you have this long common left. And they don't show the caudate branches, but there will be pesky little caudate branches of both the vein, artery, and the bile duct coming off kind of near the confluence. So you just have to be aware of those. And then just like the vein, you can have a trifurcation. You can have kind of what is a Nakamura D, where the right posterior goes into the left. And then this is a rare variant, but something that general surgeons should be aware of when doing a cholecystectomy. The right posterior sectoral duct can drain right into the cystic duct. So most people think that a duct of Luschka is probably not real, and it's probably a right posterior sectoral duct. Or it could even be, the right posterior sectoral includes segments 6 and 7. I forgot to pimp Maria on that when she told us anterior and posterior, but so this is 6 and 7. You could even have like a 7 branch or a 6 branch that's coming out and draining aberrantly into like a cystic duct. And if you get into that doing a gallbladder, you're going to call it a duct of Luschka, but it's really a small posterior sectoral duct. Now, if you ligate a posterior sectoral duct doing a gallbladder, is it the end of the world? No, the posterior sector will probably atrophy somewhat because it doesn't have biliary drainage, but some portions of it will drain through the anterior system, and then the rest will just atrophy. So if they have a healthy liver, taking away the posterior sector is not the end of the world, but these can lead to pretty significant bile leaks if you come across them and don't clip them. And if you can identify it, obviously, and preserve it, then just clip the cystic duct above this and leave all this intact. All right, so there are these anatomic variations that you just have to be aware of. I will say that the biliary anatomy is harder to elucidate pre-op, because particularly if it's not dilated. So a dilated bile duct is really hard to see on any imaging. So we typically use MRCP to visualize the biliary tree, but you can really only see the common hepatic duct and below. You can maybe see the beginnings of the right and left, but if the biliary tree is not dilated, it's very hard to visualize on imaging. And so that can create problems if you're running into these anatomic variations and there's no real way to anticipate them. All right, questions about anatomic variations at all? I'm going to assume no, keep going. All right, so risk factors for cholangiocarcinoma. Can anybody give me some, maybe like 2 or 3?
Carson has said PSC. Beth said something, but it was quiet. I couldn't. That says liver flukes and parasites.
Yeah, liver fluke. So Clonorchis is like the one that'll be on your ab site. We'll never see that most likely, although every once in a while, but it's more common in Southeast Asia. And so it's pretty unusual in people, at least who grow up in the United States. Now, immigrants from Southeast Asia could certainly have that risk factor. And then PSC, yep, that's good. And then anything else?
McGovern says choledochal cysts.
Yeah, good. So perfect. I think that's all it. So the biggest thing to keep in mind is that most patients will have no risk factors, but choledochal cysts, liver flukes, and then chronic inflammation such as PSC. The other thing is recurrent infection. So it's a little bit of the chicken or the egg, but that's probably why like Clonorchis causes cholangio, and some patients can get primary biliary stones, probably from infection in the first place, but those are associated with cholangiocarcinoma as well. And then if you have like a bile duct injury and do it's one of the reasons people don't do as many choledocho duodenostomies or hepaticoduodenostomies anymore, is that you'll get some reflux of food particles from the duodenum into the bile duct, and that can cause chronic cholangitis, which can cause cirrhosis, but also cholangiocarcinoma. So anything with chronic inflammation can obviously cause cancer. And then smoking is a risk factor for everything. Okay, there are a few types of cholangiocarcinoma. Does anybody know anything about this? This is kind of like the rest of this lecture. I sort of expect no one to know anything, but that's okay.
No, types of cholangiocarcinoma, kind of like where they are located along the bile ducts. A lot of people are murmuring. Connor,
Yeah.
any is bring a guess. What's Connor? What's Scott?
So there are
Yeah.
two ways to think about types of cholangiocarcinoma. I should have been more clear. So there are anatomic divisions, but then there are also biologic divisions. So I'm talking more about the biologic for the moment, and then we'll talk about the anatomic.
So Beth says sclerosing, nodular, and polypoid. Are you referring to the intrahepatic variants like the
No.
periductal?
So yeah. So what Beth, this is very confusing too, because different people use different names for these things. But yeah, Beth, that's sort of what I'm referring to is these are the three that most people use these names. But mass forming, which basically means that they make a tumor, and that's probably mostly going to be intrahepatic calangio. And then there's periductal infiltrating, which are these ones that grow along the ducts. And these are really the most problematic ones, I would say, because it's really hard to get negative margins. So what you'll find if you read about resection of like a Hylar Calangio is that the risk of positive microscopic margins is very high, probably somewhere around 50%. And so, chasing margins is a little bit controversial in the setting of these periductal cholangiomas. And how do you know it's periductal? You really don't until you get the path back, but they have kind of a pattern a pattern on imaging where you won't see, like if they do cholecystoscopy and put a scope up, they won't see a polyp or any sort of intraductal obvious lesion, but there will be all this stuff around the duct on imaging that just kind of looks like inflammation and stranding, and that's the tumor. So the tumor is kind of growing along the outside of the duct. And it kind of grows like weeds on a tree or something like that. It kind of grows up and down. And those are the ones that are really difficult to resect, because you'll take out everything that you can see, and then you'll end up with a microscopically positive margin, potentially on both sides, which is no fun. Excuse me. And then the intraductal, those are the ones where you might actually see like a luminal defect on imaging, and when they can put a what's called a spyglass, which is a little tiny scope that goes up the bile duct, and they might actually see a little tumor in the bile duct. Those are a little better biologically, and they're easier to resect because you know exactly where the tumor is, and they don't tend to be as infiltrating as the names might imply. And then the major anatomic variation is going to be, our division is intrahepatic and extrahepatic, which I think you guys were talking about. All right, so this is just kind of a picture summarizing that. So mass forming, these are typically going to be in the liver, and they're going to look like a tumor of the liver. That could be a colorectal met, could be a gastric met, could be a HCC, or it could be a cholangio. Now, hepatocellular and cholangio look a little different on imaging, but a lot of times it can be difficult to tell without a biopsy. And even more confusing is you can actually have mixed type. So you can have a mixed type cholangio that's sort of like half cholangio, half hepatocellular carcinoma. And so that can really be confusing as to what type it is and what to do. We'll talk a little bit about how to treat those. And then the periductal and intraductal can happen in the liver or outside the liver. So you can get a periductal that's growing intrahepatic along the ducts, and you can get an intraductal that's growing in a duct and blocking it. But those can also happen extrahepatic. So that's kind of the breakdown. Questions about any of that? And then the other thing to know is that the hilar, so happening around the hilum, is the majority of cholangiocarcinoma. So intrahepatic cholangiocarcinoma is actually relatively rare, and in some ways the easiest to deal with. But unfortunately, Hylar is the most common, and those are the most difficult to deal with as well. All right, so what does an intrahepatic cholangio look like? It looks like an adenocarcinoma of the liver. This has calcifications. This is not actually the best picture. I couldn't find a great picture, but it just looks like, it doesn't look like a hepatocellular carcinoma, but it has some enhancement. So it'll typically be an enhancing mass. It's not a clear like arterial enhancing and venous washout like hepatocellular. It'll be a little bit more of mixed enhancements, a little bit of arterial, but more venous phase enhancement like most adenocarcinomas. But it just looks like a mass in the liver, and it's not that easy to tell what it is exactly just by looking at it. So the workup for, we'll get to that in a second actually. All right, and then extrahepatic calangios, there are 3 different types. So we talked about Hylar, and then the other types, surgeons kind of talk about the other types. It's not a clear distinction biologically, but the management of these are very different. So maybe one of the senior residents talk to me about how you would resect a mid-duct versus a distal cholangiocarcinoma.
So a mid-duct could potentially be dealt with an isolated bile duct excision and a jejunectomy, but a distal would typically require a Whipple or a pancreaticoduodenectomy.
Right. So the one thing you don't want to do is a liver resection and a Whipple. And so that's where the mid ducts become a little bit of a challenge. So Alex, in the operating room, how would you approach that? How would you, let's say you have a tumor that on imaging appears to span, from just above the cystic duct to, right around where the pancreas starts. What operation are you going to consent the patient for, and how are you going to make your decision in the operating room?
To be honest, I mean, I guess if it extends that far distally, my inclination would be to do a Whipple. As far as an intraoperative decision making, I'm not sure. But if it only extends proximally just above the cystic, that should give you adequate length for a Roux-en-Y HJ to reconstruct without necessarily the need for a liver resection, as I understand it.
Yeah, so
I'm not sure exactly.
That's kind of the trap of these tumors, right? Is that sounds great, but the imaging is often very misleading. So that's one of the kind of take-home points about cholangio, is that imaging often underestimates how extensive the tumor is. And so a lot of the decision-making has to be made with frozen section in the operating room, or you just have to say, I'm going to accept an R1 margin and move forward. So that's the hard part about these, is that these mid-duct excisions, it sounds great to say, well, I'm just going to take out a piece of the duct and move on, which in some patients might be the appropriate thing to do. So in an older patient who's not going to tolerate a Whipple or something like that, you can just say, I'm going to accept an R1 margin and we'll radiate them post-op. But the reality is you have to often make these decisions intra-op based off of, what it feels like grossly, and then frozen section. So the way that these are approached, the first thing you typically do is a portal lymphadenectomy, and then you check for nodes outside the porta that might be positive. And then Alex, what if you had a positive, one common thing to do is to start with a Coker and then take an aortocaval node. And this is all controversial. This is not clearly the right answer, but Alex, let's say your aortocaval node was positive on frozen. What would you do?
I mean, at that point, those patients have such a poor prognosis that it would be reasonable to stop unless you have some other palliation that you need to do in terms of biliary treatment.
Yeah, so stopping would probably be the right answer at that point, because that is considered essentially metastatic disease. Like you said, these mid-duct, particularly mid-duct cancers, you can make an argument to resect all of them just for palliation, because it's so painful to get them drained, and then they have to have stent exchanges and all this stuff. And the reality is resecting the middle of the common bile duct and taking a gallbladder and then doing a hepatico-J is not that high risk an operation, because the duct is going to be huge that you're sewing to. The one problem is that you might be sewing to cancer, which tends to not heal quite as well. So it just depends. You don't want to sew to a gross cancer, but if you have a microscopically positive margin and you sew to it, it's not that big of a deal. So anyway, the way you handle it in the operating room is you do your portal dissection, you have the artery, the duct, and the vein kind of dissected out. And then what you typically do is you go down as low as you can on the duct, which basically means that you're pulling up on the duct out of the pancreas. And then you throw a clamp on it as low as you can, and then cut it, and then send that for frozen. So that's your distal margin. You send that for frozen. And then you keep working. You're basically, the way you do it is you cut it here, and then you're flipping the duct up, and then basically dissecting it along with all the lymphatic tissue up towards the liver, and leaving the artery and vein behind, but taking basically everything else so that you get all that lymphatic tissue around the duct. And as you're doing that, you'll get your frozen section back. So now you have to make a decision. Let's say, Alex, your distal frozen is positive. What are you going to do at that point?
And assuming the proximal frozen is not also positive, I suppose. But
yeah, good. That's a perfect answer. So the answer is you would get up above the tumor and send a proximal frozen as well. So that's the mistake there, I think. And this is like an oral board scenario for Sir-Jonk, is that people are like, oh, I'll do a Whipple, and then the proximal is positive, and now you have positive margins on both sides, which is again a fairly common scenario for cholangiocarcinoma. And you've done a Whipple for an R1 resection, which is not what you want to do. So yeah, it really depends on your proximal. So if you're proximal, let's say you get up and you cut right at the confluence, and that's negative, and the patient's 55 and otherwise pretty healthy, what would you do, Alex?
Then I would do a Whipple.
Yeah, I think that's reasonable. Some people would say the biology is the biology. This is clearly an infiltrating tumor. You're not going to save this patient. Just, resect as much as you can and then radiate. But I think doing a Whipple and being aggressive in that situation is very reasonable. Now, if your proximal is positive, what would you do?
I would probably conclude and give them some form of palliative biliary decompression. I would give them a Roux-en-Y hepaticojejunostomy to allow their biliary system to drain, but I would not further resect.
Yeah, and it's not necessarily palliative, right? So that's still therapeutic in that situation. You just know that you have an R1. So it's not like it's an R2 and you left big bulky tumor behind. You would still try to clean out the nodes and get out everything that you can, because for a focally positive margin, you can do radiation and have some pretty good results. So what I would say is that, yeah, you might even try, that's the really hard thing about cholangio, and we'll talk a little bit about this, is that you can keep creeping. It's just a question of how much you want to do and why. So, you could take another slice here and here and then sew to 2 ducts, and that's not unreasonable. Most people will chase the margin once. If you get 2 positive frozens, you should definitely not keep chasing. And again, it depends on the patient. If the patient's 80 and you don't want to do a liver resection, or you're worried about doing 2 anastomoses, then it might be reasonable to just stop there. But again, these ducts should be big and dilated. And so, sewing to a left and right that are big and dilated and kind of chronically inflamed, and the wall be thick, it's not the end of the world. And so there's a lot of difficult decision making about cholangio. That's just sort of a case to try to elucidate that. But yeah, mid duct, try to do a duct excision only, and then hepatic OJ. And then you have to make sure you ligate the distal duct well. You don't want that to leak. But that's all you really do. You just cut the distal as far down as you can, ligate it, and then march up, kind of flip the duct upwards until you get above tumor, and then send a frozen. And then if those are both negative, you just make sure you do a good lymph node dissection along with it, and you're done. So, okay. So does anybody know anything about Hylar Calangios? What the classification are, what it's based on?
Again, lots of folks are murmuring, so I think lots of folks are familiar with it.
Well, pick somebody and make them go through it.
Kat's making a lot of eye contact, like she might be familiar with it.
So she's so excited to tell us.
Kat, can you take us through bismuth correlate 1 through 4 for the peri-Hylar? Just shout it out, because it's hard for Dr. Vreeland to hear.
Yes. Type 1 is distal to the hepatic confluence.
Type 1 is distal to the hepatic confluence.
Involves the confluence.
Type 2 involves the confluence.
Type 3 is what is distal. So it's like 1 is the right hepatic, sorry, A is right.
So 3A involves
Good. Yeah, I can hear. I can hear. She's doing great.
and so forth.
Yeah. Okay, good. So one thing, I should have got a better picture of this, but one thing to understand is the way that these are classified. You can draw a line at the top of the confluence and then at the bottom of the confluence. And a 1 is below the bottom of the confluence, and a 2 is above the bottom but not above the top of the confluence. And then the 3s are extending above the confluence to one side or the other, and then 4 is both. So yeah, you got through those pretty well. So the key to understanding which one of these you're dealing with is to understand the biliary anatomy. And what, Alex, I was asking you this, what are you looking for on imaging to understand where the tumor is?
You would, presume its location based on whatever upstream ducts are dilated.
Yeah, so one of the kind of take homes about cholangio is it's not about where the tumor is, but about where the tumor isn't, kind of. So you don't have to see the tumor to know where the tumor is. You have to see what the effect of the tumor is. So that's where these Hylars, that's what it's all about, is like on a 1, it's a 1 because you can see the entirety of the confluence on the imaging. You can see where the 2 ducts come together all the way to where there's a common duct. That's a 1. With a 2, you can't see the confluence. You just see 2 ducts that are cut off, and they're cut off very near what you think is a confluence, very near each other, and they may be sitting right next to each other. That's a 2. And then a 3A, you basically see a giant left system, and then the right system gets cut off somewhere higher than the confluence. That's a 3A. And then the opposite for a 3B, right? You see this big dilated right system, and you can see a common right. So you see where the right comes together, and then you don't see where the left, you don't see that kind of long extent of the common left. And so that's a 3B. And then 4, you just see like a bunch of little ducts. You don't see any common right or common left. Make sense? So how are you gonna evaluate that anatomy? What imaging are you gonna get for these patients?
Frequently, these patients will present already having a CT, but I think a MRCP prior to any decompression of their biliary tree would be ideal.
Yeah, good. So you gave away my trick question already, right? So that's the really important key to understand with cholangiocarcinoma, and unfortunately, one that none of the other doctors in the hospital ever seem to understand, is you have to evaluate the biliary anatomy before you decompress. So the only way you can tell what's going on is because these ducts are big and dilated. So if they decompress the biliary tree before they get good imaging, and a good imaging does not mean an ERCP of the abdomen and pelvis. But if you decompress before, then you'll never get the good imaging that you need, and it makes it virtually impossible to do any preoperative planning. Okay, so we talked about MRCP. What other options are there?
People have said CT. There's other.
Okay.
There's other,
if you were going to do a CT, how would you do it?
Yeah. I would do a 3-phase CT of the liver.
Okay. Anything else you want to specify?
Oh yeah, I mean, you want arterial, portal venous, and delayed phases, if that's what you're getting at.
Yeah, and the other thing I would always emphasize is try to get 1 millimeter cuts through the biliary tree. So try to get them to do 1 millimeter cuts from above the confluence to below the pancreas, and really that just means do fine cuts through the upper abdomen because they don't know where those things are. But a 3 millimeter cut CT scan is not super helpful, but a 1 millimeter cut CT scan, I would argue, maybe the best imaging that you can get if you're looking for the tumor. So that's one confusing thing here, is that I think MRCP is probably the best way to see the biliary tree. But if you're trying to see the tumor itself, that is where a CT biliary protocol is super helpful. And the reason that that's important, so I just said that it's all about where the tumor isn't, not where the tumor is. But we're going to talk about one specific thing you got to think about. And that's where CT comes in and is very helpful. But let's talk about what are the other things you can do to image the biliary tree.
Other folks have been mentioning EUS and ERCP.
Yep, good. And then one last one.
And then PTC.
Good, PTC. Okay, so MRCP, again, it's great for seeing the lumen of the biliary tree, but it's not great for anything else. So if you want to see the tumor itself, you have to get an MRI abdomen in addition to your MRCP, because an MRCP, they're only going to give you this, subtracted out basically T2 of the biliary tree. So you're going to see this really nice imaging of the biliary tree, but you're not going to see any tumor around it, and the relationship between the tumor and what is super important for whether or not you can resect it.
Someone murmured vessels. I'm not sure who. They
Yes,
don't want to take credit.
vessels. That's exactly right. And what vessel is really important for a cholangio that's down in the mid duct, or even Hylar's?
A lot of people are saying right hepatic artery.
Right hepatic artery. Good. I want you to all remember that. Right hepatic artery. So that's where I think a CT is super important. So getting this, so this is an example of probably a periductal cholangio. The bile duct is big here, but then you see all this infiltration around the duct and into the portal structures. And this is on a CT with fine cuts, right? So you see the hepatic artery is narrowed as it passes by the tumor. This is unresectable, or you at least have to do a right hepatectomy. So it's a little hard to tell, but it looks to me like this is going to be unresectable because it looks like there's stuff all over and it's touching the vein too. But the point is, you're going to make your decision about what operation to do based off of this decision about the right hepatic artery. We'll talk about that in a minute. So, that's where I think CT is super important. So the radiologist will say, like, why do you need an MR and a CT? And I think this is why. You need an MR to evaluate the biliary tree, and then you need a CT to evaluate the vessels. You can, sometimes on a good 3-phase CT, you can see exactly where the biliary tree gets cut off too. And so in that case, you wouldn't need the MRCP, but it's pretty rare to not get an MRCP because usually they get it before they call us on these. Hopefully they don't just decompress first, but anyway. All right, and then ERCP, the reason ERCP is so helpful is because it allows for imaging and intervention. So particularly for a tumor that's a little more subtle where the biliary tree isn't hugely dilated, an ERCP can show you kind of a subtle narrowing of the bile duct. And then it also allows for biopsy for brushing. So that's a typical, if you have kind of a subtle narrowing of the bile duct, they don't like take a big bite of it. They just do brushings and then check for any abnormal cells. All you get is cytology on that. So you don't get a true biopsy. You just get some cells for cytology, but that can give you a diagnosis. And then it allows for internal drainage of the biliary system. There's a lot of controversy about the best way to drain the biliary system in a cholangio. I'm not going to go into it too much, but if you put a stent across the ampulla, what's the downside to that, Alex, since you're right there?
Are you referring to a higher rate of postoperative infection after you resect and reconstruct?
Yeah. So again, super controversial, but you're going to get some colonization of enteric bugs in the biliary system, and bile should be sterile if the ampulla has never been violated. So putting a stent across the ampulla potentially contaminates it with enteric bugs. What's the other way to drain the biliary system?
Externally.
Yeah, so PTC, right? So the problem with doing a PTC is you're going to contaminate the biliary system with skin flora. So it's not necessarily better. Maybe it's a little better. It's, again, very controversial, but people have strong feelings about that one way or the other. One thing to keep in mind for a cholangio is do not use a metal stent. So for pancreas cancer, or even for distal cholangio, where you're really just trying to open this up and this is all going to come out anyway, and you're not dissecting directly around the duct when it's in the head of the pancreas, right? You just sort of take it all out. You never actually dig that duct out. Metal stents are great because they last longer. They have a higher patency. But if you're trying to open up an occlusion higher in the duct, always use a plastic stent, because those metal stents cause a lot of inflammation. And so if you put a metal stent in up here, you could potentially turn a resectable cancer into an unresectable cancer, because it can get so stuck to the portal vein that you can't get it out. So always plastic stents for these high biliary obstructions. The downside is patency. So those plastic stents last about 6 weeks. So if you have a stent in for more than 6 weeks, they almost always have to be exchanged. And those patients they'll get cholangiocarcinoma cholangitis from the stent being occluded. And one of the things, if you've never seen somebody with really bad cholangitis, is that they get sick very quickly. So if you ever have a patient with a biliary stent who has a fever, they need to come into the hospital immediately and be evaluated, because they can go from like having a fever of 101 at home to being floridly septic in 12 hours. So any patient with a plastic stent and a fever needs to come in for evaluation right away. These are sort of neither here nor there asides, and then the PTC, so you can image the biliary tree with a PTC, yes, but it's really more about allowing for drainage. So if you can't drain it internally, or for some reason you don't want to drain it internally, then PTC is a good way to drain the biliary tree. Okay, questions about any of that? So on the topic of draining the biliary tree, why do we need to drain the biliary tree for a cholangiocarcinoma? And what part would you drain for a Hylar?
So you need to drain it so that, I mean, you can get coagulopathy in a perioperative setting from congestive hepatopathy, and then you will also be damaging your future liver remnant. So it's best to drain the segment that is going to be left behind. Is that what you're getting at?
Yeah, exactly. So you want to drain your FLR. So, and this is another thing that like the GI doctors or IR may be confused about, is they'll be like, well, the left is easier because the duct is more dilated or something like that. And so they'll just drain whatever's easier to get the bilirubin down. You're really not looking to just get the bilirubin down, because again, coagulopathy doesn't happen until your bilirubin's like 15, which is, fairly unusual in these. And so it's not that you're draining it for the coagulopathy, you're draining it to keep the liver remnant healthy. So this is just one paper, and there are other papers that have demonstrated the same thing, but this is for patients with an FLR less than 30%. So these are patients that are at risk for post-hepatectomy liver failure. And essentially, if they have pre-op cholangitis and they weren't effectively drained, their risk of liver failure was much higher, and the risk of death was much higher. This is FLR a little bit higher. You still see the same trend, although not significant. And most people would agree that if the FLR is like over 50%, and they have a healthy liver otherwise, probably not as big of a deal. But if you have a borderline FLR anywhere less than 50%, we should drain the FLR and get it well drained and the bilirubin down before we go to the operating room. And you definitely don't want to operate on somebody who has cholangitis. So if they have active cholangitis, do not take them to the operating room at that time. And that can be a problem because it can be very difficult to drain these patients. And so they're like suffering from recurrent cholangitis, and you're sort of eager to just go in and take the problem out. But those patients can die if you operate on them while they have cholangitis. Everybody understand what I'm talking about there? I know Alex does, but are there a lot of blank stares in the room, Alex? Or?
People are heavily engaged. This is, yeah.
Heavily engaged, good. So, yeah. So, all right, so let's talk about how to work these things up. So I'm going to move along a little bit just because we're running out of time. But so, much like any biliary cancer or any GI cancer, you're going to get a CT chest, abdomen, pelvis. So make sure at some point you image their chest just to rule out metastatic disease. You're going to get a CEA, CA19-9. No tumor marker is that good for these. So we get CEA, CA19-9, but they're not as good as like pancreas cancer or even colon cancer. And then again, the 19-9 will be falsely elevated if the bilirubin's up. So you have to check a 19-9 with the bilirubin below 2.5 for it to be reliable. And then, get LFTs to look for cholangitis. And then the other thing I throw in for extrahepatic calangio is we always check an IgG4. And the reason that this is so important is, like in pancreas cancer, it's important if you can't get a diagnosis. If you can't get pancreas cancer back on a needle biopsy multiple times, check an IgG4 just to make sure this isn't. What does IgG4 cause, Alex, since you're there?
It can be associated with autoimmune pancreatitis
Yeah.
and retroperitoneal fibrosis.
Yeah, so autoimmune pancreatitis for your AB site, IgG4 autoimmune pancreatitis, just keep that in your mind always. But it can also cause autoimmune cholangitis. So patients can get the same effect around their bile ducts. So if you have this infiltrating thing around the bile duct, they biopsy them a bunch of times and they never get cancer back, check an IgG4 just to make sure that it's not some autoimmune process that can be treated with steroids. Okay. So again, we talked about this, get your good biliary imaging before the biliary tree is drained, just determine the level of obstruction to understand where the tumor is. So this is one thing that I was taught that I always thought was really interesting, is to look at the gallbladder. So sometimes it's really hard to tell what's going on you can see the confluence, but then it kind of cuts off near there and you're not sure. If the gallbladder is dilated, then you know it's not a Hylar Calangiocarcinoma. So that's a nice little trick, because the gallbladder won't be dilated if the obstruction is in the common hepatic duct or above the gallbladder. So that's just an example of kind of look at what's dilated, and that'll help you understand where the tumor is. So essentially, in order to be able to resect a tumor, you need to be able to have inflow, outflow, and biliary drainage, right? So you find a dilated duct that you can sew to, and you say, okay, great, I can resect everything right up to there, and I can sew to that duct. But you got to make sure there's also arterial and portal inflow that you're going to be able to save. So I don't know why I wrote good there. I think I meant good biliary drainage.
And you're feeling extra good.
Yeah, I do. I feel good today. So that's where that right hepatic artery comes in, right? So you might say, well, I'm going to do a left hepatectomy because I have a great right duct to sew to, but then you're not really looking close enough. And then you get in the operating room and you can't get the duct off the right artery. And then you're like, oh crap, what do I do now? So you want to really try to understand all these things before you make a decision and go to the operating room. Okay. I think, I don't know why I showed this.
The gallbladder dilation thing or something?
Oh yeah, probably. Yeah. So this is not a Hylar Calangio because the gallbladder is dilated. So this has got to be a mid duct cancer. Okay. Okay. So distal cholangio, how do you treat a distal cholangio? We kind of talked about this, but this one fairly straightforward.
Yeah. That says Whipple.
Whipple. Good. And then the other thing that's kind of, you guys all know how I feel about neoadjuvant therapy. The standard for distal cholangio is definitely surgery and then adjuvant therapy, because it's just not very common and nobody's really studied neoadjuvant. I would not hesitate to give a patient neoadjuvant if I could convince the medical therapist or the medical oncologist to do it, because again, the same concerns are going to be there about the receipt of adjuvant therapy. So if you do a Whipple on a distal cholangio, a good portion of those patients are not going to be ready for chemo post-op. The hard thing about distal cholangio and cholangio in general is that there's really mixed data on the effects of chemo. So let me try to get to that, because I do think it's important to understand. Okay, so how do we resect these? Sorry, was there a question, Alex?
We only have one M&M today. If you want to run a few minutes
over,
okay.
That's fine. Well, if you give me permission to run over, you got to be careful. I might go for 2 or 3 hours. All right. So again, it's more about what we leave behind than what we're taking is kind of the way to think about these operations. So we need at least 30% FLR. We need a well-drained FLR, especially if the FLR is going to be less than 50%. And then we need inflow and venous drainage. The venous drainage is usually not a problem, but the inflow is the real problem, right? So we got to be careful about the artery and portal vein feeding that part and what the tumor's relationship is to that. So, and then biliary drainage. So the biliary drainage is going to come in the form of us sewing a piece of bile to whatever bile duct we can find in most cases, but make sure that you're going to have effective biliary drainage of whatever you leave behind. So you can't be taking, additional branches of the bile duct without consequence. So this is like an R1-2 question. Which side of the liver is bigger, and what percent of the liver is it in most patients? The right or the left?
So the students are all in agreement that the right side is bigger. If maybe one of the R2s wants to answer the percentage question. Murmurs of 60 and 70.
Yeah, 60 is probably the number to keep in mind. There's a lot of variation, right? So not everybody's created the same. And so that's why we measure segmental volumes and calculate which is what's what. But the point is that the right liver is bigger. So whenever you can, you want to try to leave the right liver. But the left has certain advantages. One is that the left artery usually doesn't come that close to the duct. So the right artery passes right behind the duct. The left artery kind of stays away from the duct. And then the other advantage is that the left has that long common duct that's extrahepatic. So you can creep back on the left a little bit more and you're able to potentially get a negative margin. So if you have a tumor that's right here, a type 2, there's a lot of debate. What should you do? Should you do a right or a left, or what should you do? The other thing, I'm not going to go into this, I'm just going to tell you, the other thing that you should probably do in a Hylar Calangio is take the caudate. So, again, there are these little branches coming off the confluence that go to the caudate, and the tumor will often creep up those into the caudate. So you could do this great resection, do an extended right hepatectomy, everything's great, you get negative margins, and then your caudate margin's positive. So most people just resect the caudate when they take a Hylar Calangio because they don't want to mess around with that. Some people debate whether or not to do it. If you can see on the imaging that the caudate branches are dilated, then most people would say definitely take the caudate. If they're not dilated, there's some debate, but it's not that hard to take the caudate while you're there. So most people would just take it. I don't know, I lost my train of thought there. But so, again, with a type 2, what are you going to do? Take the right, take the left? In my opinion, it depends a lot on what's going on with that right artery. And then, you want to look at the right portal vein on the imaging as well. So if you can leave the right, you're leaving more functional liver in most patients. So that's great. So try to leave the right. But if the right artery is involved, you may have to do a left. Now, again, in most patients, and some it's even more dramatic, some people said 70% for the right, and that's true in a lot of patients. So you might be at a borderline FLR just by doing a right hepatectomy and taking the caudate. And so that's where you kind of have to think about what to do and what to leave behind. And that's where the FLR really comes in. And so if you're going to leave the left, you definitely need to drain it pre-op. And then, you should think about volumes, and then you could get into all kinds of complicated things like portal vein embolization, et cetera. But that's sort of beyond what we're going to talk about today. So does that make sense? Just, it's more about what you're going to leave behind. Make sure you leave enough liver behind, and then they got to have good arterial and portal venous flow. And then, the other thing, again, when you get in the operating room, these are approached basically the same as what I talked about before. You do your portal lymphadenectomy, make sure there's no extra portal nodes, and then you cut the duct and flip it up. And then you just peel the duct up off the vessels and then cut the duct where you're going to cut the duct. But if you get in the operating room, sometimes you don't know for sure, and then it's stuck to the portal vein. That's a problem. So that's the real bugaboo of these, is that often you have to abort intra-op because you can't get it off the portal vein. And then you've probably cut the distal duct, so you have to find a way to restore flow. And so then you're doing a palliative resection and trying to sew to some duct, and it can be very uncomfortable. And sometimes you're forced to do a right or left hepatectomy in the setting of what is going to be a positive margin at the portal vein. And that's unfortunate, but it happens a lot. These are tricky tumors. Okay. So extrahepatic calangio, I feel like, this is just kind of what we do. So after you've resected, if you've had an R0 resection, controversy, we'll talk about that in 1 second. R1, most people would argue to give chemo, and then I would give radiation as well, wherever you had that R1 resection. And then unresectable, you're going to do microsatellite instability, check for that, as about 10% of these patients may have that. And then transplant. So another huge controversy with Hylar Calangio is resection versus transplant. So the criteria for transplant is a tumor less than 3 centimeters, no positive node, no intrahepatic mets, and no metastatic disease. So if you have a Hylar that you can't resect, and you can tell that on imaging, that patient should be evaluated for transplant, because in transplant, they can potentially resect like a right hepatic artery or even a common hepatic artery to an extent and get away with it. Whereas with resection, you may not be able to do that. So there are some who advocate for transplant evaluation for all Hylar Calangios, area of great controversy. But transplant is an option if, again, if it's not an extensive tumor, but it's just in a really bad spot, making resection hard or impossible, then eval for transplant. And then metastatic, they have a few options, chemo basically. All right, intrahepatic, we're going to do the same workup. And then intrahepatic's a little more simple. You just kind of resect it like you would a liver met or hepatocellular. There's no real strong data for anatomic versus non-anatomic. Most people just resect non-anatomic and get a gross margin of a centimeter or so. And then lymphadenectomy, controversial, but I was taught to do a lymphadenectomy for all cholangiocarcinomas. And so I do a portal lymphadenectomy as well. Interestingly, prognosis doesn't have that much to do with tumor size for cholangio, but has to do with lymph nodes, vascular invasion, and multifocal disease. So an intrahepatic calangio is just treated like most any liver tumor, resect it, okay? And then the same contraindications really exist. So if there's a lymph node beyond the portal nodes, if you have METs or multifocal diseases, questionable. But if you have a lot of these calangios, you'll see it'll be one big mass and there'll be a bunch of satellite masses around it. And those are the ones where it's really questionable whether resection is going to help the patient. And so in my hands, that patient would get neoadjuvant, and I'll try to get the data for that real quick. So the other thing I wanted to say is for metastatic disease, FGFR2 and IGF1 are commonly mutated, and those are targetable mutations. That's probably beyond what you guys need to know, but if anybody is curious, those are kind of like the cutting edge stuff for cholangio. Okay, so we'll talk briefly about the data on chemotherapy. The data is crappy because the problem with all these trials is that they throw all biliary tract cancers together. So they're going to take gallbladder cancer, Hylar Calangio, distal cholangio, intrahepatic calangio, and put them all in one bucket and then study that. And that's probably the wrong way to do it. But the problem is they're all so rare that it's really hard to do a study of just like gallbladder cancer, although there are some studies ongoing now. But this is the trial that you guys should be aware of if you're going to be aware of anything, the BILCAP trial. This is a phase 3 trial, 447 patients. I put 8 years on there because I think it's super interesting. It took 8 years for them to enroll 447 patients for this trial, which speaks to how rare these cancers are and how hard it is to run these trials. So they were all resected with curative intent. And then basically you see that there's all these mixed cancers. And the results are a little bit mixed. So the intention to treat was statistically significant for improved recurrence-free survival. The per protocol of overall survival was not different. The intention to treat overall survival was very minimally different. So there's, this is the standard of care. If you read the NCCN guidelines, everybody with an R0 resected biliary tract cancer should get capecitabine, but I shouldn't say nobody, a lot of people don't practice that. So it's sort of the Wild West with chemo for these patients. Like people kind of do what they think is the right thing to do, even though the data is out there, but it's not that good. So again, the primary outcome of this trial was overall survival and intention to treat, and it was a negative trial for that. So the p-value was over 0.05. So it was a negative trial for overall survival, but the intention to treat recurrence-free survival was better with capecitabine. So this is the data that kind of points to giving chemo post-op for these patients, and it's not very strong. ABC01 trial, this was, again, a phase 2, only 86 patients. This is unresectable, so advanced biliary cancer is what the ABC means. So these are unresectable or advanced, and they were randomized to GEM versus GEM-CIS. And GEM-CIS did a little bit better, but the p-values were non-significant because it was underpowered. So some people use GEM-CIS, but this is the data. It's not great. And then the PRODIGE 12 trial was a French trial, phase 3, 100 or about 200 patients over 5 years. And this was GEM-OX, so strong chemo versus just observation. And the interesting thing about this trial, again, only 200 patients, the recurrence-free and the overall survival numbers, they look good, but the p-values were not significant. So it's probably underpowered to show a difference, or chemo just doesn't work that well for biliary tract cancers. That's, again, controversial, but this is a disappointing trial because it basically said chemo doesn't work for these tumors. But again, if you look at the numbers, it seems like there's definitely a signal there. And then again, the toxicity was pretty great. So grade 3 toxicity, 62% versus 18%. So there's real toxicity to GEM-OX or GEM-CIS, and yet no great data to show that it helps. And then this is just to show the mutational burden of these tumors. I'm going to skip this if you guys don't care. Okay. So if you have an unresectable cholangiocarcinoma, the newest kind of latest, greatest thing out there is what we call neoadjuvant GAP, which is gem, Abraxane, and a platinum. So this is a phase 2 trial. Again, it's not a huge trial. These are the outcomes of each patient. So it's 50 patients. But they gave patients gemcitabine, cisplatin, and nab-paclitaxel. And you can see that most patients had some response. So the progressive disease is over here, really not a lot of progression and a fair amount of response. And the problem is that the prognosis for these is not that great. And so what do you do with those patients who are kind of borderline resectable and you're going to do this big operation and not help them? And so I think the field is moving more and more towards neoadjuvant for those patients. And this is the regimen that we're giving. But it is pretty toxic. All right, gallbladder cancer. Do I have 5 minutes, Alex?
You do. Lexi or Flynn, I forget which, will also be covering this in the coming weeks too.
Oh, that's right. Okay. Well, yeah. So it's all based on the T stage. This is just a preview then. So if it gets into the perimuscular tissue, it's a T2. If it gets past the lamina propria, it's a T1B, and that's kind of where we draw the line. Once it gets into the muscle, past the lamina propria, then we're worried about metastatic disease. So we do a radical chole with lymph node dissection. Always do a diagnostic laparoscopy. These are the risk factors for peritoneal disease. Peritoneal disease is super common in gallbladder cancer. I think I never actually did a radical chole for gallbladder cancer in fellowship. I think I went to the OR with 4 or 5 and they all had peritoneal disease. So definitely do a diagnostic laparoscopy before you make a big whack in these patients. Okay. I guess we'll talk about that more. There is some data on meta-analysis that chemo helps if you have positive margins or positive nodes. Again, the data on gallbladder cancer and chemo for gallbladder cancer is really confusing and not straightforward. All right, I think that's it. That was a bit of a whirlwind.
Okay. I just had one question back on your slide about the treatment of intrahepatic cholangiocarcinoma. You mentioned obviously the EGD, colonoscopy, and biopsy.
Oh yeah.
If someone has typical imaging features and say risk factors suggestive of an intrahepatic cholangiocarcinoma, my understanding is that you can proceed, but frequently these patients will come to you or be referred, or on a biopsy they'll have non-specific, adenocarcinoma not otherwise specified, and that's why you're getting at the EGD and colonoscopy.
Yeah, exactly.
Is that
So
accurate?
yeah. So like you said, there are stains that they can do to try to differentiate a biliary tract cancer from other adenocarcinoma, but a lot of times it's hard to do, and so they just say, well, we can't tell you for sure. So I would say you should pretty much always get a EGD and colonoscopy just to make sure that this isn't a met from something else. And that's particularly true on your board. So on the oral boards, you should always get an EGD and colonoscopy, because they'll just give you this liver mass and say biopsy's inconclusive, we can't tell, blah blah blah. So always look for metastatic disease first. And the imaging characteristics of cholangio are not that specific, so that's not going to be super helpful. It could easily be a met from a colon cancer or something. And so yeah, you can. I mean, if you can't get a diagnosis, you can always proceed to resection. That's true of a lot of things, but ideally trying to get the diagnosis up front is ideal. But to your point, if you have like an easily resectable tumor and the EGD and colonoscopy are negative, and they're not a cirrhotic, and you don't think it's HCC, it's very reasonable to go cut it out without a biopsy.
Yeah, that's just one point for the juniors. Frequently it comes up, common for pancreatic and other biliary cancers is one of the subset where a biopsy is not mandatory before proceeding to the operating room.
Yeah, and for extrahepatic cholangio and or concern for that is a very common scenario. It's very difficult to get a diagnosis on those tumors. So particularly with the periductal infiltrating, right? So you just have this like narrow duct with some gunk around it. And they can try to do EUS FNAs, and we've had a couple patients recently just like this, where they FNA some tissue and get atypia but no cancer. And it's like, and then the other thing that's tricky is when you do a brushing, that you have to make sure, if you have control over this at all, you got to do the brushings before they put a stent in. Once they put a stent in, the brushings are basically meaningless, because you'll get atypia back anytime you've instrumented the duct, you're going to get some proliferation of atypical cells. So if somebody has a stent in and then they pull that stent out and do a brushing, they'll get atypia, and that's meaningless. So you can't operate based on that. But there are very few things that are benign that stricture the common bile duct. And so if you have a narrowed common bile duct in a 70-year-old smoker, it's almost always cancer. And it's very difficult to get that on a biopsy. So a lot of times in those cases, you're going to the operating room without a diagnosis. Now, again, if it's like a mid duct and you can just do a little bile duct resection, that's diagnostic, therapeutic, and palliative. So you should have no qualms about doing that, right? But if you have to do a right hepatectomy or a Whipple, that's where it's really difficult if you don't have a biopsy to justify doing it. So those are the really difficult cases. But if you just have a narrowing of the common bile duct, just go resect it, because the chances are it's cancer. And, again, chemo is not that good. Surgery is the best treatment for that. And so if you can catch it early and take it out, you shouldn't really have any anxiety about not having a biopsy in that case. A liver mass, again, it's pretty easy to get a good biopsy of a liver mass. So I think getting a biopsy there is pretty easy and probably the right thing to do. But those biliary tract, the true bile duct is very difficult to biopsy. So you're stuck with brushings or biopsying the tissue around the duct. Or they can sometimes do a biopsy with cholecystoscope, but not very often.